I refuse to let my doctor lower my estradiol levels? I'm Dr. Valorie Davidson from Progress Your Health.
And I'm Dr. Robert Maki from Progress Your Health. So our community sort of wrapped up
Mm-hmm.
this last Sunday. Today actually is
Yep,
Sunday. We're
yep.
recording this video. So it's like the first initial launch. We closed the doors as of midnight tonight. Okay, so by the time this podcast airs, the community will be closed down. We got a fairly decent turnout. What do you
Yeah,
think?
yeah. We wanted to keep it small and intimate, so we
hmm
don't want to have, we want to keep the number right now exactly where it's at. So I think that'll be perfect. And then as we're developing it, then we'll possibly, maybe let other people enroll later. But we're gonna just keep this group small.
Yeah. We're kind of building it sort of from the ground up, kind of a bare bones, kind of a very foundational spot, and grow it into some what our intention is to grow it into a really nice resource. We have one international member. She's actually from Greece, which I thought is pretty fantastic. So, and then of course a bunch of other people from the United States, which of course we would expect to see. So. We'll see how that goes. Keep everyone up to date on that as far as when we decide. We're probably going to open it one more time in 2025, and then have a bit of a bigger push and a little bit of a bigger launch, so to speak, in early 2026. Is that sort of what we thought about?
Sort of, just it kind of depends, because I like the group that we have right now. So
Yeah,
I want to just sort of keep it that way. I think they're amazing, brilliant women. So I'm ready to kind of get involved with them.
absolutely.
But, we have a wait list. So if somebody is interested on it, we can, wait list and an application. But I think we'll just kind of see moving forward what we decide to do with it.
Absolutely. All right. So today we're going to respond. Actually, this comment, I guess it's more of a comment than a question, just came in just a little while ago. So it's like hot off the press, but it was an episode we did a while back. So why don't you go ahead and
Okay.
read the comment/question.
All right, here we go. This was in response to us talking about estradiol levels and changing biased or estradiol levels and what levels they should be at in your blood. So she said, "You want her estradiol on the low side? Question mark. I feel terrible when my estradiol is 48 to 51, and I have to pretty much beg my doctor to get it back up over 60. 60 is the minimum to get rid of the hot flashes, and it needs to be higher than that to have the benefits for the bone, the brain, and heart. I'm an exercise physiologist and I work out daily, taking care of my heart, muscles, and bones. I've never taken a birth control pill. I want to I want to collaborate with my doctor, not give up authority over my body. As she lowered my estradiol levels, I've watched my cholesterol levels rise and my ability to tolerate exercise go down. The whole idea is crazy. Is she going to lower my thyroid levels too?" I know I know. I understand. It can be scary.
Yeah, sure.
hmm
Well, she's got some numbers sort of dialed in there. So she's talking about an estradiol level 48 to 51. I love how narrow it is, right? So she's attributing those numbers to how she feels,
She feels bad.
and rightly so.
hmm
I can totally get it. Menopausal number on a blood test, right? It's going to always be, most of the time when you're not on HRT, it's going to say less than 30. We were talking about this in the last couple of episodes. Where are those numbers? Where does a menstruating number? Where does a woman's estradiol level go when she's in the throes of her reproductive years? It varies quite a bit over the course of a month that no one really ever understands because no one tests anything, right? And then now a woman's in menopause and everyone's sort of finding it strange that they don't feel good when their estradiol level is below 60.
And I can understand it. I mean, some people feel great at 60, some people like this comment here, and some people feel great at 40.
hmm
Everybody's different, but like you said, in a menstruating cycling female, their estradiol levels go up very high,
Yeah.
but then they come down to have a period. So that's the natural cyclic behavior of the ovaries. That's natural.
Yeah.
Now, when you're doing a static dose, which it looks like this commenter is doing a static dose, it's the same dose every single day, all day, 24/7. And so I can see the hesitancy of the practitioner not to want that level to go up too high because you have these estradiol levels at the same height 24/7. And that's not exactly natural, but at the same time, we do need those levels of estrogen to protect our bones and
Yeah.
our heart and our, and our brains and our skin and our hair. So Sometimes static dosing is a little bit of a push and pull. You can't get it all with static
No,
dosing because
no.
you don't want to have your levels too high continuously. You have to have which is why we've always talked a lot about rhythmic dosing. Now, I love static dosing. I have lots of patients on static dosing.
Honestly, that's probably in our practice, in most practices, that's probably 98% of what most women are going to be on or choose to
But
do.
not your patient base.
Oh no, I'm just saying in general. If you look at all, women that are on HRT, the majority of it is going to be some form of static dosing.
Absolutely. Yeah, that's why I'm saying we have a lot of patients on
Yeah,
rhythmic dosing,
yeah.
a lot of patients on static dosing. So it really depends on the person because rhythmic dosing isn't for everybody.
No.
Some people hate it and some people love it. So that's why I really liked this question because she's right. I mean, she exercises. She obviously takes incredible care of her body, which I love. So, but when those estradiol levels drop, when you see in menopause, the cholesterol goes up. It increases your risk factors for metabolic disease.
Yeah.
It increases your risk factors for dementia and cardiovascular disease and osteoporosis. So but it is kind of right now with hormones being so hot, we want to have the levels up to protect the bones, the brain, the heart, our bodies. But you have to be careful about where you're going to put those levels.
Yeah.
So it's interesting how to tease this part, tease this part a little bit because humans the women as humans, we need to be advocates for our own hormonal health.
Absolutely.
But at the same time, so you can see there's like this tug of war between her and her physician.
Well, I think that and we mentioned this on the last episode too. I think there's still a little bit of a fear around estrogen that nobody wants that, and their fear of cancer, okay, probably more breast cancer than uterine cancer, just in general, and maybe rightly so. Both. I think the risk is more on the uterine cancer side. That's why we're always talking about these blood levels of why on static dosing you don't want them to be too high. I don't think there's very much risk at all of HRT. Actually, I think there's a reduction in risk of HRT and breast cancer. What are your thoughts about that?
Absolutely. I don't, no, HRT doesn't cause
No.
breast cancer.
No, it does not. No. Now, where I think it gets a little bit confused sometimes as far as that goes is this is where you get an oncology report back or a biopsy report, and it'll say estrogen, progesterone receptor positive or HER2 positive. That's where the hormones can promote the cancer.
Well, you mean accelerate it, doesn't
Well,
cause it.
well, initiate. So something initiates the cancer, the tumor growth. Okay,
But not the hormones, not the HRT.
yeah, something does.
Okay.
Now, I think it's more on a metabolic side. And in America too, 13% of women, whether they do HRT, are going to get cancer. Either way. So, environmental. She mentioned birth control pills. There's lots of things there that potentially can drive some of that cancer risk. HRT, I don't think does. It doesn't, like you said, it doesn't initiate, but it potentially could promote just because the breasts are hormone sensitive tissues.
So meaning if you happen to get cancer, that the HRT could kind of put fuel on the fire.
At least from a conventional oncology mindset, right? It's really challenging, right? Because you and I prescribe HRT. In our practice, we have had very, very low cancer risk. I mean, we could in 20 years we can count them on two hands.
Yeah, how many people I've seen with cancer, and some of them because we're naturopathic doctors, that some of them we don't do HRT in all of our patients. We do a lot of it, but there's a few that have come to me because of that. So we work on that from a different side point.
Sure, right. You would think if there was granted, I'm getting off topic here, so we'll get back to her. We'll get back to her comment here in a minute, but that's why I think the doctor wants to keep lowering that number because there's this overarching fear. Now, granted, it's getting a lot better. Like you can see it all on social media. Before there used to be this kind of black cloud connotation that hormones were bad and hormones are going to cause cancer, and I think that that mindset is changing drastically. That belief, I think, is fading very quickly.
Yeah, no, I agree, but there's still. You do see this with practitioners. Some are like, "Here, take the hormones," and then don't even ask you questions or
don't do any labs.
Yeah, or check your family history, check your personal history. They're just slap on some hormones, take some hormones, and then there's other doctors that are very apprehensive about it.
Yeah.
And you got to understand, as a physician, you've got malpractice that you got to pay for.
Do no harm.
Liability that, you're really trying to do the best care for your patients and what,
Right.
So I can see where, but at the same time, there's, us women do need to advocate for our hormonal health, but maybe if the physician isn't, maybe they're not a good match, that could be possibly too. I would say for this comment, I would say, she takes such great care of herself. I mean, exercise physiology, and she works out and eats really good, that she is a perfect candidate, to do the HRT. A lot of us are. Some women, when they come to me, we don't initially do the HRT right off the bat because there may be some other aspects that we're looking at. That's, we've got to get their metabolic health in order. We've got to change up some of their lifestyle and their dietary components, and then we can add that HRT in there. Because some women, have sensitivities to the HRT. You give them some estrogen, they get puffy, they get itchy, they have a little bit of a histamine reaction. So it really is having that communication with your practitioner and having that relationship, which it looks like she's worried about this relationship with her practitioner because she's worried that it looks like she's on thyroid too, that they're afraid that they're going to lower her thyroid levels too.
Yeah. Now, I think that there's, the numbers. Now, granted, when you're using estradiol, depending on, she doesn't mention what her dose is. She doesn't mention the type of estradiol that she's using, which is totally fine. But if her level was at 60 and now it's at 48 to 51, is that really a dosing change issue, or is that just a timing of when she went to the lab? Right? Because we both know that those numbers don't stay in the blood levels very long, right? So you get them to rise a little bit after application of some sort, and they're going to, those levels are going to fall right off the further you're away from that last application.
And that's if you're talking about applying a transdermal estrogen cream. So I highly doubt that she's on an oral.
She's not, I can't
but
imagine
she could be
she's
on
not.
a patch.
Yeah, patch probably,
right? A patch could, she could be on the estradiol patch, so checking it that way. But you're right, if you're doing a biest, and let's say I put my estrogen cream or an estradiol cream, I put it on at 8 o'clock in the morning, and I go get my blood drawn at noon, the level is going to look different than if I went and got my blood draw at 4 in the afternoon.
Yeah. So there's a lab timing issue. There's our application to lab timing issue. We've seen a lot of these numbers over the years, right? And those estradiol numbers, they sort of either stay in a very tighter range depending on the person, but they don't really bounce around too much. Again, based on those other timing factors, trying to keep that consistent from one lab draw to the next.
And she's probably pretty good with her practitioner. Most practitioners, us as well, say, hey, if you're going to do a transdermal cream, apply it here. Do your blood draw, between 5 hours, anywhere between 3 to 6 hours later. And then I always look at the timing compared to their previous blood draw when they had that done versus the current one. So I bet you that's pretty consistent for her. And like she said, she feels terrible when it's lower and feels greater when it's up at 60 or a little bit over 60. So she knows that.
Yeah, sure. And I think that every woman would feel better with higher estrogen levels. The higher the estradiol, within reason, of course, but the higher the number, the better it is. Same thing with men. You got a testosterone of 200 versus a testosterone of 800, you're going to feel quite a bit different. So why, so really the issue though is, you can understand why she wants a number over 60 because she feels better with more estrogen, right? I think every woman does relatively, right?
Yeah.
But chasing that number and pushing that number up a little bit too high, again, where is that cutoff for you? They're using whether it's the patch or biased or whatever, where's the cutoff for you on a static dosing blood level?
With static dosing, I don't like it over 100 continuously.
Yeah.
Really don't. That's just, I think, sure, in the short term, they're feeling great, but what are you looking at years down the road? So there's that aspect to it. Now, with the rhythmic dosing, where you're changing the estradiol throughout the 28-day cycle, that I feel very comfortable with because if you have a uterus, they're having a period, it's keeping it's keeping them safe. And then we do the blood work and the testing, and you're changing that because you're mimicking nature. Where with the static dosing, I really don't like it over 100. And we've talked about this before, even if she's not spotting, even if she's not noticing any cramps or any symptoms like that, it still might be a good idea on static dosing to do a transvaginal ultrasound every once in a while.
Sure. Yeah.
Just to make sure that lining is accumulating
right.
and you have no idea it is.
Yeah. Yeah. We've talked about that many times. I think it should be kind of like the new standard of care for women that are, because HRT is so popular now, it should just be, in some ways you trade out the PAP and do the transvaginal ultrasound instead, or do the PAP every few years and do the transvaginal ultrasound as part of an annual exam. I think that that's a little bit of a better trade-off, especially if they're on HRT. If they're not on HRT, then I don't think it's really as important or necessary. But if they are on HRT for exactly that reason. So really, at the end of the day, you got static dosing and rhythmic dosing. You can only get so far with the static dosing. Is that sort of what it sort of
It really
boils down to?
It really is. It's easier because you're just applying the same dose every day,
Yeah.
and not, most practitioners understand what static dosing is and they have experience with that, so they can prescribe that. I would say in the case like this, especially since, she already is doing brain, heart, and bone protection just with her exercise
Yeah.
and her lifestyle. Like,
Yeah.
that's huge. She's already doing that. The HRT is important to be helpful with that, and she can see her cholesterol rise when her estradiol goes down, but she already is really taking an active part in longevity. So I can truly see that. I would say at a 60, I have no problem. I have patients that are at a 60, but as a practitioner, and probably her practitioner as well, if you did a transvaginal ultrasound and that lining is super, super thin, it'd probably be a sigh of relief, like, oh, okay,
Everything's
at
good.
60, it's
Yeah.
fine. Yeah,
Yeah,
that's
everything's good.
estradiol level of 60, it's fine. That uterus is being taken care of. That's probably all she needs to do to really have that communication with her practitioner.
And push that dosing a little bit if the lining is right where it should be.
Yeah, if it's thin, and then the doctor, her doc would be like, okay, I feel comfortable with this. So and her doctor may have suggested that, but every practitioner, it's an art and a science. They have their own ways of doing it. Like, I don't tell you how to do things. You don't tell me. I don't always, don't I? But I still want to respect what other practitioners are doing.
Of course.
Because, so I can see where it's a little bit of a tug of war on this part. But I will have to say, you're mentioning something about estradiol. I think it was maybe 2 weeks ago or something. I said something like I had a headache or I felt weird. And you're like, you just need more estrogen. So that is your answer for everything. Just take more estrogen.
Well, for over the years, to her point, she feels better when her estrogen level, her estradiol is higher. That is sort of like across the board that a woman's going to feel better with more estrogen. That is just something that I've observed both personally and professionally. More estrogen, feel better, right? Now, that's not to be coy or making any fun of anyone. Over 20 years of, sorry for clearing my throat into the microphone. We should have like a cough button or something. Observing women for a long period of time, there is a definite correlation to having a really good estradiol. When we're doing the rhythmic dosing and a woman's, blood level is, 275, 300, 327, they usually feel pretty darn good at that point, and they're like,
But it's not consistently at 300.
Well, that's on
just for
that
part
when
of
we
that
do
cycle.
when we do rhythmic dosing. That's on day 12, right? So day 12, when you do it, it rises, it falls, it rises, it falls, peaks on day 12, it tapers off drastically on day 13, and it sort of is minimized towards the end of the month, like you said. Then she's going to have a period. That's the big trade-off. That's the part that keeps women safe. But the part that most women don't really want to deal with anymore once they're in menopause, right? Which I totally understand. But in her case, she's the profile, this particular person. She's working out. She's, like you said, she's doing the lifestyle things. She is, and if you're trying to chase the numbers, right? If you're really trying to chase those estradiol numbers, rhythmic dosing is the way to do that. You're trying to optimize your bone, brain, heart health, your exercise performance, all those things. The rhythmic dosing is the way you're going to do that. You're going to have a really hard time trying to optimize anything with the static dosing, which is why we talk about both of those, because they're two completely different philosophies. You cannot achieve the blood levels with the static dosing that you can with the rhythmic dosing.
And, there's so many more symptoms, like, this commenter's alluding to, than just hot flashes.
Yeah.
Like, for example, I have this patient and she would get a lot of muscle pain, especially thigh pain. And that, joint and muscle pain is really common when that estradiol goes down.
Yeah. Oh, yeah.
So I put her on rhythmic dosing about 3 months ago, and the muscle pain has gotten a lot better, but she's still having it in one particular spot on her leg. And so I'm having her, I didn't change the dose just yet because I want her to tell me in her cycle when it gets better. Like, does it get better on day 12 when those estradiol levels go up? Or does it get better on day 21 when the progesterone levels go up? So
Yeah.
she's looking for that, but we did notice over the course of the last 3 months doing the rhythmic dosing that her muscle pain got so much better,
Yeah,
which
right.
other doctors were telling her and other people were telling her it was in her head. Like, how can you have muscle pain? You're in your I think she's in her mid to late 40s, and there's nothing, she didn't twist it. She didn't hurt anything. There's no injury. She didn't pull it skiing or something. It's just this random muscle pain and joint pain that was happening, and it wasn't autoimmune or ruling that out. Nobody could figure out why, but of course it was the hormones because that's such
Yeah.
a common symptom. But a lot of times we just sort of blow off these symptoms as, oh, I didn't sleep good last night, or I didn't eat well last night, or maybe I exercised too hard, or maybe you need to exercise more, or maybe you need to
Yeah.
stretch more, that we just kind of blow off some of these symptoms. But there are so many things that happen when you have that hormonal decline.
Yeah, absolutely. And I've seen that, of course, I've seen that as well too. You give them some estrogen, especially at a physiologic dose that rhythmic dosing can do. And there's a lot of customization. Really, if you want to tailor something to a person or an individual, rhythmic dosing is the way to do that because you literally are making the starting and the dosing changes based on not only their lab work, but really based on how they feel. So like you said, if their pain is increased and now you give them some estrogen at a pretty good dose that rhythmic dosing does, and their pain gets better. I mean, that's subjectively that's an amazing thing. And then now, like you said, you sort of track that on the follicular phase versus the luteal phase. What I've noticed, again, usually more estrogen, they feel better. When you start them on day 1 of the rhythmic dosing, they get up to day 12. Usually there's an increase in how they feel. They feel better as they get closer to day 12. And then as you get away from day 12 and you get more towards the higher, you start the progesterone and then get towards the higher progesterone is where they don't start to feel so good again.
Oh, really? So you get some negative,
Well, that's the
so do you end up changing up the dosings? Because we want to feel good for most of the month,
Well,
right?
that's where the classic PMS symptoms come in, right? So a woman's going to typically feel good. Usually her period, I'm preaching to the
And
choir.
you're talking about rhythmic dosing or a cycling
Well,
female?
I'm sort of talking about both. How rhythmic dosing emulates what a cycling woman would do, right? So let me ask you a question. So when does a woman usually in her 28-day cycle, when does a woman feel the worst?
Well, that's the thing is you don't want to feel the worst. Like I just
okay.
wrote
Okay.
wrote an article on
Okay.
PMS because I think it's like 70% of women in their menstruating years will experience PMS.
Absolutely.
Right?
Yeah.
It happens, but we don't want to have
Well,
PMS.
right. Oh, right. Well, my point is that it's common, not normal, right? PMS is a sign of imbalance, right? Usually stress-driven, cortisol changes, throws off your cycle, throws off your estrogen progesterone ratio or balance, not ratio, but relationship. So then it leads to these PMS symptoms. So,
And that would be anywhere between 3 days before their period, and maybe it's minor, like a little munchies, maybe a little, cry at a commercial, no biggie. Or some women can have PMS from day 14 to their period where they're gaining weight, they're eating carbs like crazy, and then the biggest thing is rage and irritability, and then they get their period and then they feel great.
okay, you just proved my point. Okay,
Well, I'm just saying you don't put women on rhythmic dosing and then have that happen, do you?
Oh, well, no.
know you don't.
Well, no. That's why I'm okay.
I know you don't.
You're comparing what a woman on rhythmic dosing would be like in comparison to a woman who's already cycling. So some of those things do actually show up on the timing of things. So you just sort of, you just said what my point was, is that once they get their period, usually some of those symptoms go away. Okay. And then they start to feel better as they get closer to day 12, whether they're on rhythmic dosing or they're just cycling on their own. And then as they get closer back to their period again, that 7 to 10 days or the 3 to 7 days before their period, that's where those PMS symptoms might show up again.
So my question to you is, with your patients that you have on rhythmic dosing, do they have PMS symptoms?
Most of the time, no. In the beginning or the early stages, they might. Or if they do have a symptom, we are like what you're saying with your patient. We're trying to identify where does it show up. Okay, they might just notice. Like there's one I know for sure. I just talked to the other day that had a history of headaches. Right, so her headaches were menopause-induced headaches. Right, so her headaches got way worse after she went into menopause. And that's part of the reason why we chose the rhythmic dosing, because she was on the patch. It made it all worse. She really could barely function, and now she's on rhythmic dosing. We make a tweak or an adjustment every so often, and it keeps her headache migraines pretty much non-existent. Okay?
Oh, that's awesome.
Yeah.
Yeah.
So now, in the beginning of kind of figuring that out, where did those headaches show up? It was always in the PMS window, always. Right. So we just made some adjustments and tweaks, and now those headaches are relatively gone. So when her estrogen levels were higher, less headaches. When her estrogen levels were lower, more headaches. No, pretty much. I'm sure the one you're talking about with the pain, hers is probably exactly the same way. When her estrogen levels is higher around day 12, her pain goes down. As she gets closer to the end, the pain starts to go back up.
That's where I'm having her kind of track that, because I
yeah.
asked it specifically, and what about the other leg? Well, that pain is gone completely.
Right.
What's going on with this side? So we'll track that through. And that's a neat thing about rhythmic dosing is you could tweak that up. But like I was saying, I wrote this article on PMS, is when you have PMS, it's not like in rhythmic dosing, I'll just, let me raise the estradiol on this and let me change up the progesterone, and then they don't have the headaches or they don't have the joint pain.
Yeah, right.
But with PMS, you can't really do that. Those ovaries are in charge.
Oh, yeah.
So,
I wasn't trying to say that they're exactly the same. Is that the way that you look at the timing of things, you can sort of copy, not copy, but you can sort of infer what's going on to know what kind of adjustments you need to make.
So you have a little more control.
Yeah, with rhythmic dosing, you have a lot of control. That's what I'm saying, especially for someone who's so dialed in on the exercise front and the lifestyle. So, consume her diet's good, her sleep and recovery's good. All those things are probably dialed in. Now the hormones, again, her estradiol level on day 12, she likes it above 60. What would it be if it was 360, right? She'd feel amazing if it was 360. Her workouts wouldn't be struggling. She would probably have more energy. She'd have, that's sort of my point, that, day 12, those numbers, we don't want them to be super high, right? We don't want them to be, 500 plus, right? Then that's time to reduce it or make sure the timing of everything. But my whole point of that, and to agree with what she says, is that usually when that estradiol is higher, they feel better. We're just making the distinction between static dosing. You can't push it too much. If you want to push it because you feel better, then you have to consider rhythmic dosing as the safer, more long-term option.
Yeah, I think you just summed it right up.
Yeah, well, I wasn't trying to argue with you about the timing. It was just just that you see that day 12, and it sounds like your patient with your leg pain is sort of in a similar situation.
I think really I need to tweak up her estrogen a little bit, but I want her to finish out this cycle so I can see when it gets worse, whether it is, maybe it gets better on day 21 and it gets worse on day 25. So I just want to see where she is so then we can manipulate those hormones.
Yeah.
But it is really interesting on this question here that her cholesterol goes up. So that is very, that is classic. When estrogen goes down, because estrogen has an effect on the cardiovascular system and how we produce cholesterol, is you do see cholesterol levels go up in menopause.
Yeah.
And it's interesting. When I was very first in practice, I didn't know that. I thought maybe genetics is catching up with you. Maybe your family genetics is catching up with you. But pretty quickly figured out, working with women, that cholesterol goes up when that estrogen goes down.
Right.
So it is interesting with the rhythmic dosing. I do see the cholesterol levels go down, and even with the static dosing too. Truly, when we start static dosing, because a lot of women love the static dosing, you do see those cholesterol levels go down. And I don't think it's because they're eating better, which they probably are, or exercising. It really is that direct correlation between estrogen and cholesterol.
Yeah, absolutely. Even you do even see that, even if they're on a low to moderate dose on static dosing or Biased or whatever, you do see those numbers change. Now, cholesterol, we'll talk about that later. That's a whole nother topic for sure, because that, it's not really so much about the total, even though that's what changes, LDL, triglycerides. For an exercise physiologist, and I would imagine she would probably have a stellar profile, you want your triglycerides to be nice and low. I want them for my patients to be less than 75. Reference range is 150 on the high end, so you want it to be at least half of that. But a high carbohydrate diet or too much of a refined carbohydrate diet is going to keep pushing up those triglycerides. And then, of course, you want a really good HDL level.
And that's another thing, too. When your estrogen declines, your HDL levels go down. That's your beneficial cholesterol, the high-density lipoproteins. But what I found, early on it was the LDL cholesterol that would go up when that estrogen goes down.
Yeah, so you could assume then, which also I think should be part of that screening process, instead of just doing a simple lipid panel only, they should be doing a lipid panel and include an ApoB level in there. Because if the LDL is going up in a negative way, then you could assume that ApoB is going up. But she's an exerciser, she probably got a good lifestyle, so even if her cholesterol went up, I bet you it was just more on the total than her, ApoB actually becoming a problem, causing any issues.
Oh, I bet her triglycerides are like 50.
Yeah.
You know it. Just reading that comment, I know her triglycerides
And
are nice.
triglycerides, for everyone listening about that, triglycerides and insulin are sort of correlated. So the higher your insulin or the worse your insulin status, the higher those triglycerides start to go. That's why we want them to be relatively as low as possible. HDL, now granted with women tend to have a much higher HDL anyways, but when they're in that sort of metabolic dysfunction phase, those HDL levels start to decline and then the triglycerides go up. And that can be a sign. But I've seen some crazy, what's the highest HDL number you've ever seen before?
I want to say, I think it was like 128.
Yeah, I saw one that was 135.
Wow.
Yeah, I seen one of my male patients actually. His cholesterol, his HDL was like 105.
Oh, that's really good
for a man. For a man.
fella, yeah.
So
it's like out of this world. For a guy.
Yeah. Usually don't see men have a hard time getting above 50. But I've seen quite a few men that have 60s.
Yours is pretty good. I can't remember exactly, but I remember yours was pretty good.
When we did our blood work in January, yours triglycerides were like 40. Mine was like 50. Right.
Yeah.
So that's really good. Right. That's what you want. And so I'm a 51-year-old Caucasian Scandinavian mutt. Right. So, cholesterol for me and my dad died of his 5th heart attack. Right. Having 5 heart attacks. But my triglycerides were very low, and my HDL, I want to say, was like in the 60s. I want to say it was like 66 or something.
But we do a lot of walking.
Yeah, a lot of walking. Have a clean diet. So that means there's some insulin sensitivity there, which again, also what is the 4 things? The 4 horsemen: diabetes, Alzheimer's, heart disease, and cancer. Okay, those are all related to having that that dysregulated insulin status. So. This person here, the exercise physiologist, I'm sure she's extremely insulin sensitive. So you don't even have to look at someone's insulin level. You just look at their triglycerides, and if it's below 75, you can assume that they're pretty insulin sensitive.
Yeah, which is a good thing.
Absolutely. Any more comments about estradiol levels?
No, I think this is a great question. I certainly appreciate everybody that sends in their comments, and we do try to get to them. We do.
I just sort of figured something out today. There was another comment. So our video guy, he puts in the captions and does all the videos, and he was making the subtitles move back and forth.
Like jiggly.
Yeah, and I didn't know it at first. I look at most of the videos. I'll kind of scan them, whatever. It's sort of weird to see yourself on video, whatever. And then there was a comment that I saw this morning when we were trying to figure out what we were going to talk about. And there's a comment that says, "Stop making the subtitles move. It's aggravating AF." So I responded to her. I says, I looked at the video and I'm like, oh my God, that's
awful.
This is terrible. I'm going to get a seizure because this is moving back and forth. So we'll make the video guy, thanks for the very bold comment, but we'll definitely change it because I looked at him like it really is annoying, or really aggravating. So I was sort of a little taken aback for 1 second.
And there was a thumbs up to it too.
Yeah, so that means someone else didn't like it, but she actually had the guts to say something because it's so aggravating. She probably wants to listen to the video.
Or read it. Wants to read it. A lot of people read it with the sound off.
Well, I turned it on there, and it was like it's like unreadable. It's like it's like making your eyes go back and forth. Like, why would he do that? So I chewed out the video guy to make him change it. So yeah. That was at first I was sort of like put off, but then I looked at the video. I'm like, oh my God, that's
maybe he thought it was a cool thing.
Yeah,
I don't know.
Well, it won't be a trend. We'll continue because
he's really nice.
Well, of course
I love
he is.
him.
But you saw the video. It was it was a little bit much. All right. So anything else? We're gonna wrap this one up.
No, I think we're good. Yeah,
Okay.
I think we're good. I appreciate all the comments, all the questions, everything.
Okay. Yeah. Till next time. I'm Dr. Maki.
And I'm Dr. Davidson, Dr. Valorie.